In this presentation, I'll talk about a routine brain MRI search pattern. So this is an overview of the order I go when I look at these routine brain MRIs. There's a lot of variability about what different institutions include in routine brain MRIs, but typically you're going to have your DWI, ADC, FLAIR. A lot of places would include SWI or GRE as routine, but some places don't. So if it's available, I look at it. Then T2, T1 pre-contrast, which typically, again, not always, but typically is just a sagittal T1 pre-contrast image. And then the T1 post if the study is done following contrast. Note that the purpose of the talk is on just routine brain MRI. We're not going to talk about those high resolution, skull base, high resolution cella, etc., which have their own very specific things to look at, and you need to know a lot more detailed anatomy to do those. So I always start my search pattern by looking at DWI and ADC. That's just because, looking for an infarct is a lot of times the reason these routine brain MRIs are done. Now, DWI ADC, obviously look for infarct, and you start by looking at the actual DWI image, which is this. Obviously, DWI and ADC are completely related. ADC being calculated based on the individual DWI series. So I first look at the DWI, and basically anything that's abnormal on DWI is going to show up typically light bulb bright, with the exception of things like blood and susceptibility artifact, which would be dark. So you want to go very slow on your DWI and make sure to start all the way at the top. And then you sort of go slice by slice. And each slice you give a good attention, just because a lot of infarcts can be very punctate. So this is not something you scroll up really fast. You're going to go nice and slow and sort of interrogate each slice very carefully. The nice thing is, true infarcts are going to be pretty bright and they're sort of almost light bulb-like. So, they're pretty easy to detect as long as you just spend the time on each slice and don't try to rush. Again, you look everywhere, you look at your posterior fossa, etc., and reach all the way to the bottom, the bottommost image you have. Now, whenever you see something that's bright in the brain, you're not done. That particular area, you then go to your ADC and make sure it's dark. Because ADC is a true physiologic number. It has physiologic meaning about how water diffuses on ADC. On DWI, it's just an MRI type of signal. Now, if whatever signal you see on your DWI is not dark on your ADC. That's got a number of explanations. One of which is it's just due to T2 shine through of something old, like in MS, for instance. A lot of those white matter lesions can look bright on DWI, but they're also bright on ADC, which is the exact opposite, and that's just due to T2 shine through. If something's bright on DWI but sort of normal signal on ADC, that could be because it's an infarct in the subacute phase, and then the ADC has sort of pseudo-normalized already. Other things that I look out once I've searched for infarcts, I look for anything that might be layering in the ventricles, particularly the lateral ventricles. You see bright stuff here. Those could be pus or some blood. Again, dependent portions of the ventricles, third ventricle also, as well as fourth ventricle here. So just take a quick look, make sure that thing's layering in the ventricles. That's especially important in cases of meningitis and things like that, that you have pus in the ventricles. And then finally, take a quick look at the extra cranial structures, so the bone and the soft tissues. Um, DWI is very good for just detection because a lot of times things would just be bright on DWI, but it's not very specific for anything. So whatever you detect based on your DWI, you go on your other sequences and you do the troubleshooting and further investigation of signal characteristics on the other sequences. But it's good for just sensitivity and detection purposes to look for that the calvarium as well as the soft tissues. Once I'm done looking at the DWI, I typically go straight to flare images, and that's because most people have these white matter hyperintensities, and it sort of flows naturally when I'm dictating to first talk about whether there's infarcts or not, and then talk about these non-diffusion restricting white matter hyperintensities that are probably due to chronic microvascular ischemia. So FLAIR is very good for looking at the white matter. On FLAIR images, normal white matter would be a little bit darker than cortex. As you can see here, cortex is brighter and white matter is darker. So if there are hyperintensities in the white matter, those are abnormal. The nice thing about FLAIR as compared to T2, because the white matter kind of abnormalities would also be bright on T2, is that on FLAIR, the CSF is nulled out. So the CSF signal is suppressed. As you can see, the ventricles have no signal within them, and the sulci of the brain have no signal within them. And that's what it needs to be, because anything that's pure CSF is going to be nulled out on FLAIR, on a properly performed FLAIR, I should say. So when I look at the FLAIR, I first look for white matter changes and describe those. Uh, then I look at the sulci and basically all the CSF containing structures, sulci being the main thing, because if the CSF is normal, it needs to be dark, like it is in this particular case. Now, if you see a sulcus that looks bright, that means there's something other than CSF in that sulcus. Those things that are other than CSF could be anything from blood, could be pus, and could be tumor cells. So that's, it will be a leptomeningeal process basically in that sulcus. Now, if it's a diffuse, like all the sulci seem to be sort of not suppressing on FLAIR, that could sometimes be artifactual, if patient's intubated and due to oxygenation or the FLAIR is not done properly with its timings and things like that. But overall, that is not something to be ignored. I mean, FLAIR or hyperintensity in sulci is not something to be ignored. Another thing that's good to look for FLAIR, sometimes you can see vessels that are hyper intense on FLAIR. That are, I mean, the vessels tend to be in the sulci, but it won't be the whole sulcus, and it would look like really a wisp of, a curvilinear structure that's hyper intense. Hyperintense vessels on FLAIR can be seen in the setting of slow flow. So whenever you see that, do not ignore that. That is not something to be ignored. That could imply that there's a proximal stenosis in one of the proximal arteries. So always mention that and always recommend some kind of vascular imaging to further interrogate that. And then FLAIR, I find, especially if it's done with fat saturation, this particular case is not done with fat saturation. It's actually pretty good for looking at soft tissues that are the extracranial, especially for edema. Because right now here you can see there's fat saturation and fat is bright. So you can't really check for edema because edema would also be bright. But if the fat is suppressed, then edema in the subcutaneous tissues would look bright, and so it will show up very nicely. Next, I look at the SWI images. That's just sort of follows naturally because, white matter diseases you see on FLAIR, and then SWI, microhemorrhages tend to be a part of a lot of white matter diseases. So then I would, again, my dictations will flow pretty nicely. So as far as SWI, it's basically a susceptibility weighted image. So it'll be very sensitive to anything that causes susceptibility, and those include blood products, particularly hemosiderin, as well as things like mineralization and calcifications, etc. So you look for a hemorrhage or microhemorrhage, and microhemorrhage would show up as little dots here. Now, what I consider microhemorrhage are little dots of dark signal. Everything on SWI that's abnormal would be dark. So what I consider microhemorrhage is dark dots on SWI that have no correlate on any of the other sequences. That's what makes them microhemorrhage. If you see something that's dark on SWI, like for example, probably this thing here, and it also has some dark signal on the other sequences, especially like T2, that's not really microhemorrhage anymore. I usually call those hemosiderin deposition because you can actually see it on traditional sequences, and so it's not really micro anymore. You don't need this very high sensitivity sequences to see those, so I wouldn't call them micro. I'll just call them hemosiderin deposition. So here, in this particular case, you can see there's a little bit of dark signal here. This is an infarct, right? You can see there's a lot of chunk of brain tissue missing. So this is an old infarct. And having some hemosiderin deposition at the margins of an old infarct, not uncommon at all. Sometimes these infarcts have hemorrhaged, and as that blood resolves, it turns into hemosiderin, and then that hemosiderin pretty much just stays there. It doesn't go anywhere. Other things that can be dark on SWI, of course, so as we said, was calcification. So, when you have your basal ganglia calcifications of mineralization, they will look kind of dark. You can see some dark dots here. Those are not blood. Those are just calcifications and mineralizations. Even if you can't see them on CT yet, SWI has higher sensitivity for those, so you can see them. And then you can see a lot of times in the choroid plexuses, because choroid plexuses calcify, you can see some dark signal in them as well. While you're here, other things to look for any layering blood in the lateral ventricles. Very common to miss a little bit of layering blood in the lateral ventricles, as well as look around the sulci, because sometimes, again, with the subarachnoid hemorrhage and things like that, you would see these lines of dark signal within the sulci, and that could indicate subarachnoid hemorrhage. Especially if you look at your flare and there's a sulcus that's not suppressing on flare, meaning the sulcus that's bright on flare, always look on the SWI for that same sulcus and see if there's a SWI signal. Because if there's SWI dark signal in that same sulcus, that's pretty much going to be subarachnoid hemorrhage. Finally, if you read these cases in the setting of an infarct, a thrombus in vessels can have susceptibility artifact associated with it. A lot of times, these arteries on SWI images show bright signal, but when there's a thrombus there, you would see a dark signal, and it would actually be susceptibility artifact. It would sort of be blooming almost, so it will look thicker than the vessel. So if you have a thrombus, that could also show up dark. And that can actually be pretty sensitive, especially for thrombi in like these distal branches. You see like this little nice dark blob here. And because it's susceptibility artifact actually expands and it looks more prominent than the actual adjacent vessel. So the one thing is to not confuse them for potential hemorrhage, right? I mean, so if there's a thrombus in a vessel and, it'll have susceptibility artifact, don't mistake it for hemorrhage, because if you call something hemorrhage, perhaps that would exclude the patient from some therapies and interventions, things like that. Then I look at the T2-weighted images. Now, T2-weighted images I find pretty good for looking at the brainstem and cerebellum, more so than looking at the flare. You can see I just feel like cerebellum, you can see the fovea and the sulci in the cerebellum much better on the T2-weighted images, and some of the details of the brainstem also show up nicer on the traditional T2-weighted images. So I find T2 to be very complementary to FLAIR for the posterior fossa structures. Then when you're looking at these T2-weighted images, it's kind of like a cheap man's angiogram. You can see all the vessels are very dark because of their flow voids. So you kind of follow all your vessels, follow your left vertebral. You can see it's coming up, going in, just the basilar, right? And the basilar is going into the posterior cerebral arteries. So you can see basically all the vessels. You chase them and you make sure that they're all patent and this normal signal void is preserved. Especially interrogate the internal carotid artery flow voids, including in the petrous canals here. See, they're entering the petrous canals, and then the upper parts of the neck. You can see here they're coming up the upper parts of the neck. Make sure that they are, in fact, have that low signal. As an aside, this particular case, there is sort of this not abnormality, developmental variance. You have this basilar artery here, and there's another vessel coming from the basilar artery, very beefy vessel, and it's going towards this internal carotid artery. Typically, basilar artery itself isn't directly connected to the internal carotid artery on either side. There are these posterior communicating arteries here. See, this is the posterior communicating artery going to the P1 segment, P1, P2 junction. But this is not that. This is much more inferior, and this connects directly to the basilar. That's just a persistent trigeminal artery. So you can actually see vascular findings pretty well. This obviously is just a totally incidental finding of no concern. Then basically I've more or less done with the brain portion, especially in a non-con MRI. I'm done with looking at the brain at this point. So T2 luckily is very good for looking at soft tissue. So then I talk about the soft tissues. I look at the orbits. You can see the globes pretty well, optic nerves, extraocular muscles. Look for any masses that might be there in the orbits. Look at the paranasal sinuses. Again, mucosal thickening would be sort of it is brightness of the mucosa, and you can see this particular patient has some mild mucosal thickening in the ethmoids. Compare that to the sphenoid, which is pretty clear. These ethmoids, they have this periphery of bright signal. That's just mucosal thickening in those paranasal sinuses. Then you look at the mastoids here on either side. Make sure there's no effusion. If there was an effusion, you'd see some dark, bright signal within those mastoids. While you're looking at the mastoids, I typically look at the internal auditory canals. Make sure you see nice CSF within them, as well as the labyrinthine structure. So your cochlea, vestibule, you can see here your semicircular canals. Just make sure there's preserved T2 signal within those. Again, these are not high resolution images typically, so you can't say, oh, there's like a tiny little schwannoma or something, but it's still good to get in the habit of looking there, just because on occasion you will catch a bigger schwannoma that's occupying the entirety of the internal auditory canal, and you can see it'll be completely effaced and pretty evident in retrospect, especially when you look at the post-contrast image. Finally, T2s are obviously very good, I find, for soft tissue anatomy. They delineate the soft tissue anatomy pretty well. So you look at your parotid glands typically, and your muscles of mastications, anything in the skull base, your nasopharynx, those all tend to show up pretty nicely. Again, sometimes you can go further down, so you just have to tailor how much soft tissue you look at based on how far down it goes. And then you can just take a quick look at your scalp. Make sure the scalp is okay. See, this is the scalp. This bright signal here is the scalp. This dark signal is the outer cortex. Then there's the marrow that's got bright marrow in it, and then the inner cortex. So this stuff is all scalp, the subcutaneous tissues of the scalp, and this gray here is the cutaneous surface of the scalp. So finally, as part of a routine brain MRI, which is done without contrast, I go and look at the T1 pre-contrast images, which are typically obtained in the sagittal plane. Now, in the sagittal plane, it's very good for looking at gross anatomy, particular anatomy of midline structures, and some of the midline structures that I think best seen on sagittal and not necessarily on the other sequences you've already looked at would be things like your sella here. Make sure there's no adenomas or expanded empty sella. Your cerebellar tonsil locations to make sure you're not dealing with something like Chiari or intracranial hypotension, both of which present with tonsillar downward displacement of the cerebellar tonsils, as well as any sort of CSF abnormalities here anterior to the brainstem. And sometimes things like hypothalamic hamartomas and things would be like little blobs of tissue here, where the pituitary stalk meets the hypothalamus region. Then this obviously is also good for looking at the soft tissue anatomies. Typically, the sagittal includes much higher field of view. If you recall, the T2 weighted image only included up to here, right? There was no reason for them to go further down. But the sagittal includes a lot more of the soft tissue anatomy, so a lot more soft tissue to look at. Typically, what I do for soft tissues, I start at either side and I go from one side to the next. So as you're starting, the first major soft tissue organ you see is the parotid gland here. See, this gray stuff here is the parotid gland. Not uncommon at all to find a little nodule in the parotid gland, as like a lot of the reasons for incidental parotid findings is these routine brain MRIs. As you're coming down, then you see a lot of musculature, including muscles of mastication. And as you approach the midline, you go into the oral tongue. So again, see, this is what an normal oral tongue is supposed to look like with the fanning of the muscle fibers and things like that. So make sure those are all preserved. Then you reach the pharynx. So make sure there's no abnormal masses or anything like that in the pharynx. And then you kind of go to the other side. And again, the parotid glands coming through, and make sure there's no masses or nodules, things like that. Then you look at the bone marrow. So bone marrow on T1 pre, especially in adults, it needs to be pretty bright because it needs to have normal fat. And so anything sinister in the bone marrow is going to be T1 dark. So you're basically looking at all of this marrow here. You can see the marrow here nice and bright. Make sure there's nothing that's dark in the marrow here, especially make sure to look on either side at your occipital condyles. I've missed a bunch of stuff in the occipital condyle when I was a trainee of a fellow. So make sure to interrogate those and sort of look at the whole bone marrow. Then take a final look at the cervical spine, because the cervical spine, again, because such a bigger field of view is included on these T1 sagittals, you see a lot of cervical spine, and not uncommon to have little disc bulges or big herniations here. So take a quick look at those. Now obviously, if the study is done after contrast, I'll then look at the T1 post, which typically is first obtained in the axial plane and then followed in the coronal plane. And most places don't include sagittal planes, but sometimes I've seen other places in consultation that also include sagittal plane. So in the axial plane, obviously, when you're looking for enhancement, you just go relatively slowly because you're looking a lot sometimes for metastatic disease, and those be little dots of enhancement, right? So you got to go slow and to just look at both sides of the brain, make sure there's nothing enhancing. You also look for things like active inflammation. So anything you see that was bright on FLAIR or T2 on prior images, you make sure to look at on your T1 post and make sure those are not enhancing to imply active inflammation. So when you're looking for enhancement, you look for enhancement in the parenchyma, you look for enhancement in the leptomeninges, especially again, if on FLAIR you saw a sulcus that was not suppressing, you make sure to talk about whether that particular sulcus is enhancing or not. Because if it's enhancing, that guides you more towards something like meningitis or sort of leptomeningeal carcinomatosis, versus if it's non-enhancing, that's more like something like subarachnoid hemorrhage, for instance. And then also enhancing stuff could be in the dura or pachymeninges. So you just have to scroll down slowly and look for all of those things. Now, T1 post is also very good for interrogating the marrow, but typically only if it's done with fat saturation. So if it's done with fat saturation, it's pretty good for looking at the marrow. So finally, I take a look at the T1 post in the coronal plane. Now, typically the T1 post in the coronal plane is delayed after the axial, so there is actually a few minutes of delay from when the contrast is administered to when they get the T1 post axial and when they get the T1 post coronal. So in the coronal, contrast has had more time to diffuse into the brain and breach that blood-brain barrier in areas where the blood-brain barrier is no longer tight. So it is not uncommon for T1 post-coronal to have higher sensitivity for detection of enhancement. That's why it's very important to pay equal attention to the T1 post-coronal as compared to the axial, just because some enhancing lesions will only show up on T1 post-coronal, and that's presumably because contrast has simply had more time to diffuse there. So definitely interrogate all the brain, leptomeninges, pachymeninges, make sure that there's nothing enhancing. Now, T1 post a lot of times is done with fat saturation, unlike T1 post coronal is done with fat saturation, unlike the T1 post axial, and it's just really good for looking at the bone marrow. You can see here the bone marrow, it was bright on prior slice. Here's nice and dark, and anything that's bad is going to look bright and enhancing or on this coronal T1 post, and it's very nice for detection just because you see for calvarial lesion detection, especially because you cut through the bone so nicely and so in a cross section, so lesions tend to show up very nice, and you have pretty high sensitivity for detection of lesions you can see in the calvarium. So definitely pay attention to the calvarium as well. I find also T1 post obviously would be very good for looking for leptomeningeal pachymeningeal enhancement at the sort of undersurface of the brain. So, your middle cranial fossa and the skull base, the floor of the calvarium. Just because on the axials, the floor of the calvarium, all of it will be on one plane and it will be hard to detect things, versus on the coronal, you're going through numerous slices through the floor of the calvarium here. So sometimes enhancement in these regions much better seen on coronals, especially if you have like mastoid effusions and things like that, and you're worried about mastoiditis. Take one quick look on the coronals right here adjacent to the mastoids, because if you see pachymeningio enhancement, for instance, in the floor of the calvarium right next to the mastoids that are also opacified and angry, that's suspicious for mastoiditis with intracranial extension. So I think this was a nice brief overview of a routine search pattern. Again, this will not cover specific MRIs, high resolution MRIs done for specific purposes, but is a good general purpose search pattern for to use.